even when I'm on the med search floor or any floor, I always make sure, is my patient full code or DNR, do not resuscitate. That's what advanced directive means. Statement of how you want medical decisions to be made if you cannot make them yourself. Okay. um, Living will, legal document outlining care that keeps you alive. Okay. Switched around. Darn it, I don't know what happened there. The first thing, okay, so there was an incident on the unit that my friend told me about. One of the nurses failed to check if their patient was full code or DNR. So when she coded, they fully resuscitated her when she was a do not resuscitate. And guess what? The nurse got sued, the hospital got sued. Big time. Big time, big time, big time. This is why this is so important. Oh, of course, the family won a whole lot of money. Okay. Durable power of attorney. Appoint another to make medical decision if you cannot. Now, we're not talking about a conservatorship here. This is when you're about to die due to an underlying medical condition, 6 months to a year to live. This is basically an individual who's making those decisions for you because you are not competent enough medically to make those choices. Okay? Okay, this chapter consists of a lot of types of loss. Let's go over them. Normal grieving time is 6 months to a year. That's normal, right? Those of us who have coping mechanisms, we're resilient, right? If there is a death, some form of loss, and we grieve, 6 months to a year. Your priority assessment for someone who is grieving is suicide risk. Do you have any thoughts of hurting yourself? Okay, stay with the patient. If grieving longer than expected, over a year, therapy and support groups are incorporated. So, if your grieving time is over a year, this becomes maladaptive, okay? This is where you're isolated, you're angry, you don't have valid coping mechanisms, you cannot validate or justify why you are angry, but you are, because maladaptive grieving, okay? Now, there are lots of somatic symptoms during the normal grieving period time. Chest pain, insomnia, anxiety. Think about it. Correlate it this way. Something horrible happens in your family, you can't sleep, you're anxious, and your heart hurts. Chest pain, okay? Somatic symptoms with no underlying issue, okay? Now let's move on to anticipatory grieving, loss of a person with cancer before the best, or any form of end-stage illness that you know they're going to pass. A lot of my hospice patients, their family, those who are not in denial, they're anticipating this grieving process because they know that their loved one has, excuse me, like 6 months or less to live. Okay, they're anticipating it. Necessary part of life cycle. So necessary loss and maturational loss kind of go hand in hand. Necessary part of life cycle. Anticipated but maybe still intensely felt. Moving out of your parents' home, going off to college. It's a necessary loss. It matures you. Okay? Matures you, maturational. Loss is normally expected due to development process of life. Going to college, getting married, okay? Empty nest syndrome, necessary, things like that. Making sense, right? And an actual loss, any loss of value, person, or item. Maybe there's a belonging that you love so much, whatever material this is, and it's gone. Okay? It's an actual loss. Situational, unanticipated loss, car accident that leads you to an injury, or you're paralyzed. Okay? Or there's death. Okay? Disenfranchised, type of loss that is not socially accepted. Perhaps suicide. Okay? Perhaps suicide. Or maybe something that's not even spoken of. Okay? Maybe miscarriage. Okay? Am I making sense, guys? Definitely know this. Please definitely know this. I'm sure it'll be on Tan's exam. It'll be on obviously my exam, proctored. Okay, now, Kubler-Ross. Famous. I'm pretty sure you guys have heard of Dabda. Okay? Denial, anger, bargaining, depression, acceptance. I never believed that this could be a reality until I witnessed my own grandmother go through it. Okay? It's real. Okay? My uncle passed away. My mom has a sister and then a brother who passed away. And when he passed away, my grandmother was in denial. I mean, in serious denial. Okay? So this can occur to the person who is in denial, like the actual patient who's about to pass, or us, the grieving patient. I mean, the loved one, right? So my grandma could not believe it. Rejection of reality. Like, no freaking way. Okay? Now, she was not resilient, lack of coping mechanisms. Her grieving process lasted 3 years, okay? She was angry, blaming my mom and my aunt, okay? Blaming God, a higher power, okay? She would always say to my mom and my aunt, "You have no idea, I just lost my only child." She was that angry. There's two other kids, right? Bargaining. Although this seems very, how can you bargain if they're gone? But that's what my grandma did. She literally still negotiated. She thought that he would come back if she said, "Hey, I will go to church. I will do this. I will do that." No. And then the depression part, 3 years, guys, where it was fatigue. She just would not shower. She would not get out of bed. She would not go anywhere. Extreme sadness, irritability, angry. And then when she finally accepted it, she acknowledged it. It was just, at that point, I was like, Kubler Ross. Kubler Ross. It's real. It actually does happen in order. The difference is the time frame. Some people go through a different time frame. For my grandmother, 3 freaking years. Some people longer, some people shorter, but it does go in order. It really does. Maybe together, like denial and anger can be together, but it never jumps. Right? It never jumps. Yeah. I was shocked that what I was learning in school was real. Warden. Okay, so now that you finally accepted it, okay, there's this thing called 4 tasks of mourning. Warden's task. Identify 4 tasks in grieving. Accept the loss. Acknowledge the pain of the loss. Adjust to the new environment. Reinvest. Excuse me. Okay, so the tasks of grieving are not states of achievement, but it's a process that fluctuates and leads you to your new normal lifestyle. Okay, I don't remember why I wrote tear. Ignore that. Okay. Okay, so it's tasks 1, 2, 3, and 4. Know this. Know this, know this, know this. Okay? The first one, you've accepted it. You've accepted that there was a loss. Finally, you've passed through Kubler-Ross, okay? Number 2, you're finally living life and experiencing the pain of it, okay? And you're not judgmental about it. You're not angry. You're not mean to others. You're not blaming others. You're coping. You're finally coping with your day-to-day stuff, okay? Task 3. Let's say your loved one passed away. Change the environment where you live in. You can't live in the same place anymore because it reminds you of this person. Move. Okay, task 3 is when the person actually moves. Adjust to a new reality. Maybe change a job if that's where your loved one was. Okay, change the environment that you're in. And then 4, make new friends. Reestablish yourself. Move forward. Get a new job. Develop new hobbies. Okay, you're moving on in life. You're moving on in life. Okay, does this make sense, you guys? I promise you it'll pop up on your exam. Give you my word. Okay, now we're talking about more grief. Okay, normal grief, 6 to what? 6 to a year, yeah? Consists of normal behaviors, reaction to loss, and symptoms, somatic symptoms, right? Excuse me. Acute grief is shortly after the grief happens. you get a physical symptom, and it's tightness of chest. That's acute grief, where you're shocked and you get chest pain. Okay? We talked about anticipatory grief. Okay? This is kind of repetitive, but it's because it's important. Right? Process of letting go before an actual death occurs. Okay? Dysfunctional, complicated. When it lasts over a year, maladaptive. Okay? Another word for it is dysfunctional. Prolonged grief disorder. Prolonged sorrow for more than a year, where you're just stuck in that depressive state of Kubler-Ross. Okay? Disenfranchised, miscarriage, suicide, a loss that's not publicly acknowledged. Okay? And grief experienced by public tragedy. Princess Diana, Robin Williams, Anthony Bourdain, public, famous people. Right? Or, well, this is really horrible, but Gabby Petito, the recent loss, public tragedy, we all grieved. Right, guys? You guys know about that, right? Yeah. Yep. Public tragedy. Very sad. Okay, so delayed and inhibited grief. Okay. Patient or family member dies, and because the loved one who remains, okay, they're so busy with their day-to-day life and the things that they have to do and how busy their lifestyle is that they don't have time to comprehend and to take in what happened and to actually grieve. And everyone around them expects the patient to maintain their day-to-day activities. So you experience this grief later. It's delayed, it's inhibited. Okay, that's what this means. And the horrible part is that the family members expect you to just go on day to day. There are lots of people who are like this. I think these people are tough. Okay, so that's what this means. Absolutely. Now, obviously, this can vary with people depending on how resilient you are, how tough you are, but the longer you keep it in, the longer Kubler-Ross will last you. The longer your grieving time will last you, and it'll be maladaptive instead of normal. Absolutely. They're more, you become higher risk for so many different things, you know? It could. It could lead to other mental, you're talking about other mental diagnosis, leads to depression, anxiety, SI, all that stuff. Absolutely. Places you at risk for so many different things. Absolutely. That's why it's so important to give people time to grieve. Facilitate their mourning. Give them time. Don't push them. And don't expect them to go on with their lives. This is why I think it's like law. If there is ever a loss of an employee, they give them time to grieve, right? So the way you care for this person who's grieving, right? Give them time. Don't push them. Just let them be, okay? Identify what grieving they're going through. Is it maladaptive? Is it disenfranchised? What part of Kubler-Ross are they in? Therapeutic communication. Let's not challenge them, okay? We're not going in defensive. Assess the individual to accept the reality of the loss. Assess them. Okay? Assist and assess how far along they are in the grieving process, okay? Once they've accepted it, right? They're going through warden's task. Provide support. There are resources available. Cognitive behavioral therapy, individual therapy, encourage new relationships. Does that make sense? The most important thing here is grant time for grieving. Do not push them. Okay, don't push them. Now we're talking about palliative and hospice care. Very similar, the time frame is the only difference. Are you serious? They didn't give him, what? Oh. No, don't say sorry. So your cousin went to our campus, West Coast, LA. What the heck is 3 days? Oh gosh. It should be the same. Grant time for grieving for pets also. It's like practice what you preach, right? They're all about mental health and nursing. I'm so sorry that happened. Well, are you serious? What is going on with West Coast? Oh my gosh. Our slide says 6 months. Oh my gosh. You guys are like telling me all these insane things. That's very sad. Wow. I'm thinking. I'm so sorry, you guys. I don't know why it's like that. It should be the same to students. Yeah, a different school would say, okay, well, come on, it's a nursing school. I don't know what to say, you guys. I'm not sure why it's the way that it is. Today's society. Other countries are very different. Other countries are very, very different. Yeah. Wow. Sorry, guys. Seriously, sincerely. Let's move on. Our school of nursing should understand. I agree. I agree. Palliative and hospice care. I'm a hospice nurse. I do palliative care. So they're one and the same. With palliative care, goal is quality, compassionate care for people facing life-limiting illness or injury. All about pain management. All I do is I make sure they're comfortable and I administer a bunch of pain meds. Morphine is, I have a supply for the patients, right? That's all it is. Comfort. Tailored to what the patient wants, support to patient's loved one included. So I care for comfort for the patient, pain management, and I support the family. This is the time where I want to make sure, are they in denial? Are they anticipating this? Okay. It's all about medical care, pain management, emotional and spiritual. This is what palliative care is. Okay. They're still at a year with palliative care. There's still a year left. With hospice, cure is discontinued. If they refuse meds, yeah, I just document. I explain to them that it's going to make you feel better. I have some patients who refuse meds. I'm like, you'll feel better if you take this. And they're like, nope, I don't want it. I don't want it. And you guys want to know why? The pain meds are not like ibuprofen. It's like Dilaudid. It's strong meds. You guys want to know why? Opiates. What do you watch out for when it comes to opiates? What's the main thing? Addiction. Okay, but what else? Respiratory depression. They're already so close to dying. Their vital signs, as the person it gets closer to dying, their vital signs are on the floor. So if I give them pain meds, strong pain meds, they get that much closer to death. That's why. That's why a lot of them refuse. So hospice care, goal discontinued. Goals for cure is gone. With palliative care, it's not that there was a goal, it's just the length of time. Palliative care, it's like a year. So by hospice care, they're closer to 6. Again, about pain management, quality of life, comfort. Okay? My life was pants because she. Yep. Yep, there you go. She didn't want to, low level of consciousness. She didn't want it. Absolutely. Very common. Very common. Very common. They took that time to talk with their loved ones a lot. It's okay, don't say sorry. So with palliative care, it's time frame. There's a year left, right? It's time frame. With hospice care, this is when we get closer to 6 months. 6 months. That's the only difference. Otherwise, they're exactly the same. They're exactly the same. With hospice, we already know there is no goal, there is no cure. Did I answer your question? That kind of clarified it, I hope. Right? Time frame is the only difference. Um, just pain management, exactly. We're trying to maintain quality of life, focus on symptom relief, pain, all that. Again, it's all about pain and comfort. That's it. That's all. Ooh, I should watch that. Yeah. I've done hospice for what, 8 years now? Yeah. I get attached to a lot of my patients. Transference, countertransference, nursing intervention. Nursing intervention is aimed at comfort measures, pain management, and family support for the family. A lot of hospice and palliative care has a lot to do with caring for the family members. Okay, promote continuity of care, communication. So if they're on the unit and you're on a hospice unit, okay, make sure the same people are caring for these people. Don't change it up. Decrease that anxiety. Psychological care, physical care. Assist the client and family to have their end of life care and like living will, all that stuff taken care of. Protection against abandonment, isolation. It's kind of like a policy thing. I don't focus on it. Don't worry about it. And support for grieving family. Support the family as much as you can, because they are the ones who are going to go through Kubler-Ross, Warden's task, all that stuff. Okay? We are done. Oh my gosh.